Good afternoon, ladies and gentlemen. I'm Zoltán Seberin, vascular surgeon at the Semmelweis University of Budapest in Hungary. Right now, we are in the heart of the city of Budapest, and you can see the Danube in the background. If I mention heart, then you need big vessels also, and Danube is the big vessel, we can call it the aorta, which connects different countries throughout Europe. And the bridges, they can represent the symposia, which connects not just the parts of the cities, but countries and also the vascular surgeons in Europe. Welcome to Icarus.
Good morning, everybody. My name is Marek Majewski. I work in the Department of Vascular Surgery at Henri Mondor Hospital in Créteil, at the University of Paris 12. I am the Vice President of AMOV, Association des Médecins d'Origine Polonaise en France, which is the Society of Polish Doctors in France. I am a member of GMELism, Groupe d'études des médecins libéraux des Sans-Morts des Fossés Association, and an honorary member of the Polish Doctors of Chicago Society. I am happy to be living in the most beautiful city in the world, Paris, where I can take advantage of all the cultural events it has to offer. My department and Henri Mondor is well known for our use of endovascular techniques, particularly with abdominal and thoracic stent graft, which we began implementing in 1995. Now we utilize laser-made techniques to treat complex aortic aneurysm. So far, we have conducted 44 such procedures. Today, I will present a case study of one of these procedures. Thank you, and let's begin.
Good afternoon, everybody. Thank you very much, Grzegorzowi i Janowi, for the opportunity to present my case, laser in situ fenestration in the management of a complex abdominal aortic aneurysm. I would like to report a case of juxta renal AAA, anatomically unsuitable for classic EVAR because of short proximal neck and narrow distal aorta, treated successfully with total endovascular repair using laser in situ fenestration. Endovascular treatment of juxtarenal AAA can be done either by fenestrated, branched EVAR or chimney technique to prevent post-operative complications such as endoleaks or aortic ruptures. Narrow distal aorta may cause graft kinking or thrombosis. Over the last decade, in situ fenestration of aortic stent graft provide another alternative for complex juxtarenal AAA. Our case, 69 years old male smoker with chronic obstructive lung disease, asthma, Klinefelter syndrome, and hemophilia type A. CT angio showed increasing juxtarenal AAA diameter of 53 millimeters. Preoperative sizing relieved a very short infrarenal landing zone, 4 millimeters. Proximal healthy landing zone involving SMA and both renal artery is 15 millimeters. Circumferential calcified narrow distal aorta with an 11 millimeters diameter. We consented the patient for endovascular repair using laser in situ fenestration In this slide, you can see the juxta-renal AAA with very short infrarenal landing zone, 4 millimeters. And next slide shows the narrow distal aorta, 11 millimeters in diameter. As you know, the norm is greater or equal to 18 millimeters. You can see the slide diameter 53 millimeters. And on the beginning, I would like to present the equipment for this procedure. Laser generator excimer. After that, we have the 0.9 spectranetics atherectomy catheter, Aptus lancer, a cutting balloon, and 420 balloon, and stents V12 or Bentley. Here I would like to present stage of this procedure. First stage, under the image fusion, we place the stent graft at the level of the target arteries, and in third stage, positioning Aptus is very important with angulation 90 degrees. In third stage, stent graft perforation with laser atherectomy catheter spectranetics. And in fifth stage, predilation with a cutting balloon. And in sixth stage, second predilation with balloon 420. In the seventh stage, stenting with V12 or Bentley. In flaring with 10-20 balloon. And here I have the film for during this intervention. We do catheterization through the humeral artery for SMA, for security. After that, we put, of course, the stent graft at the level of the target arteries and perforation Dacron with spectranetics and stent Bentley, and we can see good vascularization SMA, and the same procedure we do for the left renal artery with stent, and after that we vascularize with same procedure with laser perforation and put in stent right renal arteries. This is at the level, the procedure at the level of target arteries, but in this case, after that, we put in the aorto-iliac stent graft, and we've closed the origin left iliac artery, and after that, we through the iliac artery, we do the perforation, and of course, left common iliac artery. And now we have the bifurcated stent graft, and after ligation stent, we have really a good vascularization of left iliac artery with vascularization hypogastric artery too. And after that, final test angiography shows permeability of the target arteries and both iliac arteries. In post-operative CT scan, 6 months after, shows patency of aortic stent renovisceral arteries and contralateral iliac stents with aneurysmal sac stable 52 millimeters. We can see in this slide the target arteries and in the transversal cut bone position. And of course, now we can see the broad iliac artery, transversal cut, which shows the good permeability of this artery, and of course the aneurysmal sac, stable, without embolic. In conclusion, laser in situ fenestration is an effective solution for complex juxta AAA. It presents a suitable alternative to excellent contraindication criteria for EVA, the time delay of fever, and avoids other conventional open surgery in the management of complex juxta renal AAA. Thank you very much for your attention. Dziękuję za uwagę. Merci beaucoup pour votre attention.
Sorry for that. At the beginning of our conference, it was a few hours before, but we have some gift, video gift from Professor Piotr Szopiński, and then we will introduce you again.
I was wondering what I might tell and show you about Warsaw, the city I was born and have been living for all my life.
For the last 10 years, we have been observing very fast development of the city. Once living in a peaceful district, in a house with a well-kept, manicured garden, 2 years ago I had to accept the decision of the authorities to build the next underground line. My garden will soon turn into the metro station called Zacisza, which means quiet corner. And it's not a joke. What all this has in common with the theme of our meeting? Well, I think it does. New technologies in vascular surgery are constantly needed and looked forward to, as without them it's difficult to imagine any progress. It's important to consider various aspects of the method of treatment employed, remembering that many of them are still in the process of development.
Progress is inevitable, yet often comes at a price.
Piotr, I was a little bit worried that you changed your profession, but at the end of this, this clip, okay, I feel better. Okay, so the floor is yours.
I'm only a vascular surgeon who are trying to introduce a new strategy, new idea, having a program of aortic arch aneurysm stent grafting, and we are trying to go forward with this very attractive technique that is still not very common in different countries. Can we have another slide, please? Okay, thank you. So, as I told you, we started to introduce in my clinic a really branch system, and until now we did more than 10 cases. Among them, there are also really, double branch stent grafting. The next one, please. I prepare a short movie about one of the patients. It was a male with asymptomatic thoracic arch aneurysm with 75 millimeter in diameter, with some anatomical problems that you can very easily see in a movie, with a very short landing zone in brachiocephalic trunk. Of course, there's many of the patients with a lot of comorbidities. And here are the CT scans and pre-reconstructions, when you can see very easily the arch type 3 that made many problems during the introducing of the branches into the aortic arch. Next slide, please. And can we move
implantation steps and device deployment? Firstly, we prepare our patient and perform the exposure of axis arteries. Right femoral for the main body advancement, right brachial for the angiographic catheter and bailout procedure, left carotid for advancement of the left common carotid artery branch, right carotid for advancement of brachiocephalic trunk branch, and left brachial for advancement of left subclavian artery occluder. The next step is to advance diagnostic guide wires and catheters through the right femoral and right brachial arteries. Main body implantation. Just before introducing the main body, we place a double curve Lunderquist stiff guide wire into the left ventricle. The primary sheath is advanced up to the distal landing zone until the first third of the descending aorta. In this case, we decided to bring the primary sheath slightly higher than we usually do in order to overcome this severe angulation and at the same time give the system the space it needs to self-align. According to precase planning, the correct projection for deployment of the main body is 25 degrees LAO. With this projection, we orientate the main body having the D-shape marker facing the outer curvature and rotate as necessary. The initial angiogram is performed. Now we are going to visualize the left coronary and innominate arteries that mark the proximal ostium of the brachiocephalic trunk and the distal ostium of the left common carotid artery. The next step is to advance the secondary sheath to the proximal landing zone and align the fenestration marker 5 to 10 mm proximally to the brachiocephalic trunk and ensure that the proximal end of the graft is not too close to the coronary arteries. Now we start partial deployment of the main body by pulling back the constraining sleeve until its marker overlaps the S-bar marker. At this moment, we have to confirm the correct position of the main body before deployment with one more angiogram. We use adenosine to pace the patient down. It is important to perform full deployment of the main body in one single movement. The proximal clasping is released. We repeat aortogram to ensure the proper position of the main body and the flow to the head vessels. Next, we retract the tip of the delivery system and withdraw it to the distal portion of aorta, at the same time withdrawing the stiff guide wire from the left ventricle. Branches implantation. Now we are changing the C-arm projection in order to identify the internal tunnels. First, we will cannulate the anterior tunnel for the left common carotid artery branch extension. The sequence of cannulation doesn't make any difference. The anterior tunnel is approximately 5 mm shorter than the posterior one and runs on the right of the middle marker of the window. After cannulation, we exchange for the Amplat stiff guide wire and we ensure that we are inside the target tunnel using a PTA balloon 10 by 40. Next, we advance the branch extension over the wire to the left common carotid artery until we reach the proximal marker of the anterior tunnel. The tip of the system is designed in such a way that crossing the valve is avoided. At this moment, we ensure the distal position and correct landing zone. Now we deploy the branch stent graft. Full deployment is finished after we release the proximal clasp. Then we remove the delivery system and perform control angiogram. Now is the time to cannulate the posterior tunnel and extend it with a brachiocephalic trunk branch. After cannulation, we ensure that we are inside the target tunnel by using a PTA balloon 10 by 40. We inject contrast through the right brachial catheter and mark our distal landing zone. After angiography is performed, we measure the total length to be covered and to select the proper brachiocephalic trunk branch stent graft. Preparation of the device is performed in the same way as the first one. Next, we advance the branch extension over the wire to the right common carotid artery until we reach the proximal marker of the posterior tunnel. Just like with the first branch, at this moment we confirm the distal landing zone and start deployment. When the proximal clasp is released, deployment is finished. Now we remove the delivery system and perform a control angiogram. Standard relay NBS implantation. The next procedure step is the implantation of the relay NBS as the distal extension. Now we introduce a 16 mm amplatzer to the left subclavian artery, paying attention not to close the origin of the left vertebral artery. At the end of the endovascular procedure, we perform the final angiogram to confirm exclusion of the aneurysm, good apposition of all the implanted elements, and patency of the head vessels. Then we close the wounds. A control CT scan, performed 1 month after the implantation, revealed good result with no disconnections or endoleak.
Can I have the next slide, please? Okay, thank you. Sorry for boring you with this movie. It was done in a very high quality, but here I'm not. I do not like it really. So just take home message from our experience is that aortic arch is still a battlefield between cardiosurgeons and vascular surgeons. So we can choose or we can mix both technique. It all depends of patient's complex anatomy and operator experience, and of course, possibility to treat patients in a high quality hybrid room. So I think that these kind of procedures should be limited to select expert centers when the design and deployment procedure or branch endograft can be further developed to reduce stroke risk. That is a main issue for our patients. And the last slide, please. There are 2 froggies in my garden who they do not care about the coronavirus. And you can see here they are very close one to each other. Thank you very much for your attention.
Dobry, panie redaktorze, na razie jeszcze nie mogę swojego obrazu pokazać.
Tak, to jest.
Ale
wszyscy przechodzimy przyspieszony kurs Zooma, Meeta i Teamsa, ale rzeczywiście mam nadzieję, że za moment to się uda. Miło pana widzieć w ogóle, jak zdrowie?
Teraz po tym, jak profesor Kasprzak wyłączy swoje, właśnie, wyłączy swoje pokazywanie ekranu, ja już będę mógł wrócić do swojej prezentacji. Mam nadzieję, że państwo teraz widzicie.
Świetnie, tak.
Szanowni państwo, witam bardzo serdecznie. Cieszę się, że udało mi się przyjść tutaj i pokazać swoją prezentację, czy chciałbym zaprezentować swoją prezentację dotyczącą naprawdę trudnego przypadku, but finally I should switch to English because it should be done in English, so I'm sorry for those who didn't understand. Welcome, and I will show you my presentation about just standard aneurysm that has been treated several times. The case The goal of the aneurysm treatment, endovascular or open, is just to protect the patient from aneurysm rupture. Therefore, the aim of the operation is to exclude the aneurysm sac completely. Professor Kasprzak has beautifully shown us that we shouldn't leave any IMA or lumbar arteries open, but also all other feeding vessels should be treated, as you will see in this case. This is the case report of our patient treated exactly in the last month. This was a 67 years old patient with some comorbidities, with enlarging AAA after EVAR. And it has been called challenging case by a referring physician who has sent me the pictures, and he told me that he sees double lumen in the aneurysm. Maybe it was dissection, maybe it was an aneurysm. He didn't know how to describe it. And the main point is that the patient has multiple endografts implanted previously. So now you can see the CT scan of the patient, normal thoracic aorta, and then normal visceral vessels. And you see this double lumen with outflow to the hypogastric arteries. You will see it now in reconstruction. So you have a patient with endograft inside, with endoleak type 1, feeding from this left side of the patient, feeding the aneurysm sac. And this is the 3D reconstruction where you can see this endoleak and the outflow of the endoleak to the hypogastric arteries. So we're coming back to the history of the patient. 7 years ago, Zenit EVAR bifurcated was implanted. I'm sorry. And this is the pre-operative CT scan reconstruction. You see quite short proximal neck. It's about 7 millimeters in length. And you see also that there were ugly common iliac arteries aneurysms, which should have been treated at that time. Of course, you know what are the indications for standard EVAR. Of course, you know that this 7 millimeters proximal neck is not enough, but just standard bifurcated endograft has been implanted. More because you can see the postoperative CT from October 2013, where you can see endoleak type 1, and nothing has been done to the hypogastric arteries. So you see beautiful outflow of this endoleak into hypogastric arteries bilaterally. So after this CT scan, the patient immediately has had cuff implanted, because they have seen that there is still some space below the arteries, so the cuff could be implanted. And this is the picture after cuff implantation. You can see that this cuff is positioned exactly in the same place, so that it's not unexpected that there is still endoleak type 1. So 2 years later, they had an idea to place ovation endograft inside this previously implanted EVAR. And this is the CT scan after operation. You see here ovation inside Zenit with this very long ovation free flow. But of course, you can see persistent endoleak here. And 1 year ago, when they have seen it in the control CT scan, they say the patient to go home, and left him like that. So in 2020, the patient was referred to our center with enlarged aneurysm, with, of course, endoleaks from above, and we thought on the beginning that was endoleaks from below, but of course it was the outflow of endoleak type 1 into the hypogastric arteries bilateral. So the things we must have done was, first of all, endoleak type 1A closure. We know that it was impossible to do it with cuff or any other endograft that could be implanted inside. So in this situation, we have two solutions: one fenestrated stent graft or branch stent graft. We, you know, that we have a good, very good. Very big number of patients treated with branch endograft in such circumstances. So we have chosen, of course, to do branch endograft here. But also, of course, we have chosen Zenit branch because this is our favorite platform. We use it in almost every patient that is coming with paravisceral aneurysm. But of course, the second thing that must have been done was hypogastric treatment, which was even more difficult than treating this endolytic type 1. So there were many ideas what to do with it. First was to leave it alone, because we could have hoped that it will thrombose when endolytic type 1 will be closed. The second was to ligate by open surgery if number 1 is not successful. It was also possible. We thought about it. The third idea was to do bypass or transposition to external iliac pre or post-operatively, which could have protect the good flow to the hypogastric arteries, or to close the hypogastric arteries endovascularly. Of course, the question was how to do it and when to do it pre or post-operatively. And as the patient was high-risk patient, we chosen to close them endovascularly simultaneously to the endograft placement. So we made hypogastric coiling, as you can see on this slide. This is the angiography where you can see endolytic type 1A, and you can see very good flow into the aneurysm sac. So we went into the aneurysm sac with the sheath, and this is the angiography showing you that on this side, by this direction, we have made coil embolization of right hypogastric artery, and then angiography, we went here and closed the orifice of left hypogastric artery. Of course, so this is the angiography. After that, you see there is no flow to the right hypogastric. You can see this little small flow to the left because it was early after embolization. And then we decided to place T-branch inside. You see the T-branch positioned in the previously implanted endografts. Of course, we were afraid a lot of crossing all those wires because we knew that there is at least 3 layers of wires of free flow of the previously implanted aneurysm, but we have done it without bigger problems, and we have done it with big graft plus balloon expandable endografts. And here you can see the final angiography with patent all visceral vessels and no endoleak into the aneurysm sac, and also no endoleak to the from hypogastric arteries. And this is postoperative CT scan made quite early, a few days after operation, with some endoleak form still visible, but no flow in the aneurysm sac, and also no flow into the hypogastric arteries. Of course, you can ask the question whether timing of this operation was proper, whether we should divide it into the numerous procedures, because there was a risk of no outflow endolytic type 1A. Of course, there could be other methods that I have mentioned before, which are open to discussion because we have done open or hybrid surgery, but of course, as the patient was high risk patient, we didn't want to do open surgery in this case. But the most important thing is for you to remember that the aneurysm should be excluded completely during primary operation. Otherwise, we have a lot of problems which are very difficult to solve. Thank you very much for your attention.
Dziękuję bardzo. To była przyjemność, panie profesorze. Dziękuję za cierpliwość, dziękuję za wiedzę, dziękuję za energię, z jaką się pan tą wiedzą z nami podzielił. Poszło na konferencji Icarus. Bardzo dziękuję widzom za ich cierpliwość także, za to, że jesteście z nami cały czas. Możecie, oglądając tę konferencję, wybierać język, w którym ona jest dla was transmitowana i tłumaczona, ale także używać czatu do tego, żeby powiedzieć kilka ciepłych słów pod adresem tych, którzy pojawiają się ze swoją wiedzą i tych, którzy za chwilę się pojawią. Też zbieramy pytania, które będziemy w kolejnych minutach czy godzinach naszej konferencji zadawać. Czeka na spotkanie z widzami konferencji Icarus Arkadiusz Jawień. Dzień dobry, panie profesorze. Witam serdecznie, Bydgoszcz.
Hi, my name is Arkadiusz Jawień from Bydgoszcz, Poland. Welcome to Icarus.
Dzień dobry, witam serdecznie. Czy mnie słychać?
Słychać doskonale.
Okay, ladies and gentlemen, first of all, I want to thank Greg and Jan for inviting me for this interesting symposium, and I feel very sorry for the organizers, but do remember, do not give up, okay? So far it's going now not bad, so let's continue. I'm going to switch into the iliac branch device for iliac aneurysm, and I'm going to show you how I do it. These are my disclosures. It's not moving now. Okay, this is my disclosures. And the ESVS guidelines published in 2019 mention also a chapter about the iliac aneurysm. According to the guidelines, iliac aneurysm are the dilation over 1.5 times into the normal diameter. So that means that for the men, if the common iliac artery is bigger than 18 millimeters, for women, if this is bigger than 15, and for both gender, if we speak about the hypogastric arteries, when the diameter is bigger than 8 millimeters, we can say that we are dealing with a patient with iliac aneurysms. There is also a threshold for repair. And as you can see here, the diameter bigger than 35 millimeters is the recommendation for the revascularization. As you see, the recommendation is not very strong. It's only 2BC. That means that we do not have enough paper to prove that. We have to remember that overall frequency of the isolated internal iliac artery aneurysm is up to 7%. It's not too many. In the guidelines, they refer to the Roberts anatomical classification. As you can see here, the most common is type 1, which is including only the common iliac artery, and then the least frequent is the external iliac and internal iliac and common iliac. This is Reber 4. But do not forget that 40% cases of AAAs also contain the unilateral or bilateral iliac artery aneurysm. That means that we are getting into the trouble when we have such a patient. What is the treatment? Obviously open and endovascular. But if we go into the guidelines, again, the recommendation is that in patients with iliac artery aneurysm, endovascular repair may be considered as a first-line therapy. And again, the recommendation is 2B, level B. It's not very high. So what is the treatment then? There is a change in endovascular repair. Before, we are much more prone to close the hypogastric artery, as you can see here. Nowadays, when we have devices, obviously we are trying to preserve the internal iliac artery to have a patency and flow into the pelvis. How we do it? This is the technique of the Iliac graft, because majority of our cases, this is in fact 34 cases, were performed with the Iliac. We did only 2 Zenith stent grafts for iliac artery. So if you have the iliac branch, then you start with implanting the device first into the iliac artery. Then from the contralateral side, you go with the bridging stent graft, and you place it correctly into the internal iliac artery. Then obviously you implant the main body with the branch going to the contralateral side, and again with another stent graft you are connecting the iliac branch with the main body. And this is very briefly the main technique. There are certain criteria for implanting the IBD. Anatomical requirements are as such that aortic to iliac bifurcation should be more than 50 millimeters, and the inner iliac bifurcation should be bigger than 16 millimeters of diameter. The internal iliac landing zone should be longer than 10 millimeters, and diameter, it should be between 5 to 9. If it's bigger, then obviously you have to go even deeper into the branches of the hypogastric artery. The complicating factors are iliac tortuosity, iliac stenosis, and long aneurysm. So now let's go into the details. If we implant on the left side on the screen, what you see, there is a device implanted into the left iliac aneurysm. We use usually the 0.018 guide wire, and with the lasso, we are pulling down the guide wire into the contralateral side, and on the right side you will see we go with a usually 7 French sheet inside to the iliac branch device, and you can go as deep as into the branch, and then you can easily, I should say easily, cannulate the internal iliac artery as it is here. And obviously, having the guide wire into the branches of the internal iliac artery, obviously you can connect the branch with the iliac artery with a stent graft like this one. Okay, and this is the case which I want to present to you. This is the male patient, 63 years old. The indication was the common iliac aneurysm of 48 millimeters. Obviously, in addition, that was also the AAAs, but the size was obviously not a recommendation for the normal treatment. But having the big common iliac artery aneurysm, we decided to place the IBD. We usually, after angio-CT, we are doing the drawing like this one on the right side, just measuring all the diameters and the length, and then decide what sort of graft we are going to use. And this is the patient who was admitted into 2014. We implanted the aorto by iliac stent graft, and that was the iliac branch device to the left side and the bottom bell to the right side, because there was a dilatation of the iliac artery. To our surprise, the completion angiogram showed the endoleak type 1B on the right side. Everything what was on the left side was really correct, and the flow was leading into the internal iliac. We decided to leave it like this, and 3 months later we did the angio-CT, and as you can see here, there was no endoleak, so we were very happy with this. But 3 years later, in 2017, the patient came into the emergency of our hospital because of a little pain in the lower part of the abdomen. We did the angiography, and what we found here, as you can see, this is the dislocation of the iliac branch. Look at here. It was one piece of the iliac stent branch, E ventus, which fell down into the place of the dilated iliac artery. What we decided to do, we went from the arm, from the subclavian artery, went down. It was not so easy to cannulate through the branch, iliac branch, into the stent graft, which was already in the aneurysm of the internal iliac artery. But on the right side, as you can see, finally we managed. We inserted the Amplatz guide wire, which was a stiff guide wire, and based on that, we placed the stent graft, and you see the deployment of the stent graft, additional E ventus, which was connecting the iliac branch into the iliac artery to the branch which was, to the stent graft which was implanted previously. And as you can see, the completion angiogram showed very nicely. The patient is still alive, is under ultrasound monitoring and doing well. So based on that and our experience, over 40 such a stent graft implanted in our patient, I should say the iliac branch stent grafting is effective technique, is feasible and safe, but we have to remember that it offers a high technical success rate, although in some patients can be a great challenge for vascular team. Thank you very much for your attention.
Dziękuję bardzo. My także za prezentację, za dynamizm i za wiedzę, którą się dzielicie. Bardzo dziękuję, szanowny profesorze, i do zobaczenia. Arkadiusz Jawień, Bydgoszcz. Teraz będziemy w Krakowie. W Krakowie będziemy u kolejnego naszego gościa. Dzień dobry, witam serdecznie. Jest z nami Maciej Chwała.
Hello, welcome to Icarus. I'm talking to you from in front of St. John Grande Hospital in Krakow. The hospital is localized in old Kazimierz district. It's old Jewish district of the city. It was located in 14th century, and since then a lot of Jews lived here. So the part of the city is very interesting by itself because there are many synagogues, many monuments, but also Gothic churches. What could be even more interesting, there are lots of restaurants here, more than 300, and you can find whatever you prefer to eat, and you can eat as late as 4 a.m. in the morning. So if you happen to be in Krakow, please visit Kazimierz.
I hope it is working. Thank you very much for inviting me to participate in this conference. I'd like to say a few words about Shivar procedure and how we do it. So to start with, for whom the Shivar procedures is perfect procedure for the patients with juxtarenal aneurysm with short infrarenal necks, and it is one of, and actually the only one of the shelf option for these patients. How many of them? It seems that about 18% of patients are excluded from normal liver because of short neck. And for these patients, we can propose this procedure. It's actually the only procedure that we can use in emergency settings. And it is, as far as Endurant is concerned, the only kind of stent graft that is approved by FDA, and it's also CE marked solution. So we are actually working with IFU. It's also included in ESG's recommendation for 2019. So why Endurant? It is some special properties of the graft that allow us to use it as the base for the chimneys, especially that the stent graft is constructed of very short and dense independent nitinol segments forming letter M. That's why it really well adjusts to 3D structure formed by stents and aneurysmal neck. So that's why we can expect some good position, and thus we are not afraid of endoleaks so much. As you can see, nitinol is also the very important material. So nitinol adjusts much better than steel. Also, other stent grafts, which are perfectly good for forming good seal zone with normal aorta, are not so easily adjustable as Endurant's short segments. So that's why we try to use this equipment. We have to take a look at the anatomy of the neck and of the crown. We have only 15 millimeters of the free flow of the crown, of which 1 millimeter is covered by the stent graft material here, and we have only 12 millimeters below. So we have to be very careful. Actually, we can land with our stent only within 3 to 5 millimeters zone in order to avoid collision with pins of the stent graft. So what patients can we treat by this method? You have to have total neck length more than 15 millimeters. Still, you have to have sealing zone below renal arteries more than 2 millimeters. So consider this. It is very important for the sealing. No significant calcification and thrombus can be found in those areas, and neck diameter should be between 19 and 30 millimeters. As far as angles are concerned, infrarenal neck should be no more than 60 degrees, suprarenal neck no more than 45, and also supra-SMA angulation should not exceed 45 degrees. Sizing is very important here, because as you can see, if you use a stent graft, you are forming in the and also you're taking too small a stent graft, you will have so-called gutters and also the source of endoleak. So you have to be very exact. Sizing recommendations are that you should go for 20 to 30% of oversighting. You are supposed to use balloon expandable covered stents. And remember that if you're measuring, you should measure from intima to intima. Because the procedure is pretty complex, you should use good accompanying equipment. As far as sheaths, which are really crucial in this, you have to have very good hydrophilic reinforced sheaths. Recommended are shuttle from the Cook and destination from Terumo, sizing 7 French and 90 millimeters length. As far as the wire, it's either Rosen or Supracore, because you have to have relatively stiff wire with delicate, non-delicate ending, because you don't want to injure renal artery. And as far as balloons, expandable covered stents, we know people are using Advanta, Big Raft, or Livestream. Because it's very precise procedure, you have to consider 3D structure of the neck before the operation, and you have to be sure that you know what angles are important to avoid parallax error. Also, you should work on big magnifications, and remember that as contrary to normal aneurysm, when you consider the landing zone according to renal arteries, here you have to take into consideration location of superior mesenteric artery. And you have to follow the steps. So what is very important here, as I mentioned, you're working with very delicate balloon in close proximity to very sharp needles. So we all know what happens when balloon touch the needle, and then you land with a big problem because you have undilated stent when you destroy the balloon, or you're hooked to with the balloon to the needle. Both of these problems are really difficult to solve. So you should use your sheath as a shield for the needles, and then it will be safe. So we're starting with our procedures. So we chose the case with an aneurysm with a very short neck below the left renal artery. It's about 2 to 3 millimeters. As we can see in this case, we perfectly can see SMA. So we start with cannulation of both renal arteries. We put sheaths into them. We perform a selective angiogram to be sure that we are within renal arteries. And then we put the stents into the sheath and we leave it like that. Next procedure consists in putting standard putting device into the aorta. Please remember that covered stents should be relying within the sheaths, and you're landing just below the SMA. So sometimes you have to use horizontal lamp position to be sure where SMA is located. So still having stents within the sheaths, you deploy the body. It's pretty standard way of the procedures. Of course, locate the lamp in the right position. Now you release the crown, cannulate contralateral lap and deploy the limb, and you retrieve the delivery system, but you do not remove it totally because it forms some scaffolding and reinforces the structure formed by so many devices put in one place. So now it is the most important part of the procedure. You start with putting the lamp into the position so that all the markers of the stent graft are within one plane. Now you put the grafts in. The stent grafts are still within the sheaths, and you can easily move them back and forth. So you try to land, as I said, 3 to 5 millimeters above the fabric. Now you retrieve the sheaths, but only to the level where the pins of the stent graft are protected by the sheath. Now you deploy the balloons, and exactly after you did it, you retrieve the sheath onto the balloons and into the stents. Here is the pictures of both balloons deployed. Now you remove the delivery system. You proceed with typical explantation of right leg of the stent graft in this case, and then you're trying to make it all working together. So very important part of making it to seal. It is important that you follow the steps. So first you have to inflate the balloons within covered stents, as here in the picture. Only then you inflate reliant balloon, then you deflate reliant, and at the end you deflate stent balloons. Why? Because you don't want to squeeze the stents. The force of reliant with empty balloon expandable stents would squeeze them, and it would ruin all our procedure. So last step is to safely remove the stents, because once again you have to use the sheath to withdraw the stent in order not to make it hooked on the pins of the stent graft, and you perform final angiography. As you can see here, there is no endoleak whatsoever. Remember that the procedure lasts a little bit longer, and you have 2 renal arteries cannulated. So please make sure that your patient is properly heparinized. What about recommendation after the procedure? There is no mention in IFU about use of antiplatelet therapy, but because we are putting the stents into renal arteries, at least we use double antiplatelet heparin therapy for at least 1 month. Small endoleak during the procedure can't be neglected, so don't worry, it will usually seal afterwards. As far as follow-up, there are no recommendations as well for some special follow-up, but considering the complicated solution in the neck, computed tomography seems to be much better because it's really hard to visualize endoleak and the flow into renal arteries by USG itself. So if the problem of endoleak persists, you can still use bailout procedure either during the procedure or next step by using HeliFix, but remember that you should put them only below the stents. So if the neck is below the renals is only 2 millimeters to land. So it's pretty tricky. And thanks to covered stents using the procedure, you can use any embolic material within the space between stents and stent graft if there is some problem with endoleak. So when you're starting with the procedure, consider the time of the procedure and then learning curve, because there are many steps to follow. Radiation dose is also important because especially in obese patients, both for the team and for the patient, consider it well for the patients with renal problems because of long procedure, a lot of contrast and renal artery manipulations. And of course, sometimes cost of the procedure could be a problem. At least in Poland, the cost of extra equipment is not reimbursed. Thank you for your attention.